Hello, my name's Dr. Matt Kearney. I'm a GP and I'm a Programme Director at UCL Partners.
Hi, my name's Laura Boyd and I'm Deputy Director of the Primary Care Innovation Team at UCL Partners.
The next slide, please. So COVID-19 has placed unprecedented pressure on our healthcare system, as we know, and primary care has absolutely changed forever. And a major challenge for us as clinicians on the front line lies around people with long-term conditions. These are patients who've depended on regular, proactive, face-to-face care in the past to keep them well. So a key question for us now as we deal with the pandemic is how do we deliver this care, high-quality, proactive care to our patients when most things are being done remotely? So to help us adapt management of the long-term conditions, UCL Partners has developed a series of frameworks that support us to deliver our routine care, but in a way that works in this new world of primary care post-COVID. So the frameworks and the support package from UCL Partners includes risk stratification tools, new pathways that use the wider primary care team, virtual consultation, so doing as much as possible remotely, digital tools to support remote management and self-management, and finally training and other resources for staff. So these frameworks have been designed by primary care clinicians to help primary care teams deliver quality care to patients, to meet our QoF requirements and other contractual requirements while releasing GP time at this time of unprecedented demand. So moving on to the next slide. Important to emphasize that the frameworks we've developed, led by a clinical team of GPs and pharmacists, are very much for local adaptation. These are not blueprints, but they're to blend with existing local pathways and to match local workforces. But this is an important slide because this spotlights the 4 core principles that have driven this work. And this is critical. So first of all, that our interactions with patients need to be virtual by default. Secondly, that we should mobilize and support the wider workforce to help us deliver long-term care, long-term condition care to our patients. So this includes clinical pharmacists, but also other staff such as healthcare assistants, social prescribing link workers, nursing assistants, etc. But thirdly, that we should use this as an opportunity to get a step change in our support for self-management. As clinicians, we all know how important self-management it is, but frankly, we struggle to deliver it. I think many of us at the front line don't have the skills to do it, but we certainly lack the time to deliver this in our short consultations with patients. And then finally, that this should all be underpinned by digital innovation and other technologies to support self-management and remote management of our patients. So this slide gives us an overview of our approach to the long-term condition management and the framework that we have used. So you see the principles there in the top left. And we have developed search and stratification tools for EMIS and System 1, and these are based on clinical criteria, but also ethnicity and in some cases social factors. And this is to stratify patients into risk groups, so low, medium and high risk. And this allows us to do 2 things. First of all, to prioritize the care for our patients. So after this time of delay and disrupted pathways, who is it amongst our patients with long-term conditions that we need to see first? Who is at the highest risk so that we can get on and see them early and optimize their care? But it also allows us to map the workload to the workforce. So through this stratification, as well as identifying patients at the highest risk, we can also identify patients at low risk. So by any metrics we look at, these are people whose conditions are stable, that they are well managed, and they may need no or limited clinician input. But what they do need is support with education about their condition, support for self-management, support for behavior change, stopping smoking, losing weight, etc. Now, these are interventions that can absolutely all be delivered by staff such as healthcare assistants or social prescribing link workers, as long as they have the appropriate training. So the next slide lists the conditions that we have included and we have developed frameworks for. So essentially, these are core respiratory and cardiovascular conditions. So the first conditions were asthma and COPD, and we've now completed the frameworks for hypertension and type 2 diabetes. And we're currently developing frameworks for atrial fibrillation and high cholesterol. But just to emphasize again that these are frameworks, they're not blueprints, they're frameworks to be adapted locally. The next slide, please, Laura. And what I'm going to do now is I'm going to show you all of the pathways, but I'm just going to take you through the asthma pathway to illustrate the approach. And this slide shows how we have stratified the patients, or how the searches we've developed stratify patients. So we've developed these search tools in conjunction with the Clinical Effectiveness Group in North East London. And these search tools are easily uploaded into the GP systems, and they categorize the patients. So in the case of asthma, they give us 3 groups of patients. Group 1 are patients whose coded clinical criteria show that they are at high risk. So these are patients who may be on biological therapies, having frequent oral steroid therapy or frequent antibiotics, on the high end of asthma interventions. At the other end of the scale are patients in group 3 who appear to be very stable. We never see them in the surgery. They order their inhalers on a regular basis, but never need any additional treatment. Now that group we can phase for later review. But then there's a group of patients in the middle, and if we look at the coding in their records, we see evidence of exacerbations. The exacerbations might be coded as such, or they might be on having frequent courses of prednisolone or oral antibiotics over the last 12 months, or their inhaler use might suggest they're at higher risk. So this group of patients can then be further stratified using the asthma control test, which can be texted to them via AccuRx, for example, and the patients can complete this score online, and we can use that scoring, which indicates levels of asthma control, symptom control during the previous few weeks. We can use that to judge whether patients are high, medium, and low risk. And could I have the next slide, please? So this slide shows then how we use that stratification approach to determine the care that is offered to the patients. Now you will see that for the high risk and medium risk patients, what we've done there is just to group together what we know is good practice. These are really headlines, aide-memoire for local clinicians to use and adapt in the way they know best locally. In the patients who are at lowest risk and very stable, what we've done here is to show the input that a healthcare assistant or trained link worker could have to support self-management for that patient. So this could include, for example, using video consultations to check the patient's inhaler technique, and linking that to the excellent resources on the Asthma UK website that demonstrate inhaler technique, or spacer device, the use of the spacer device, for example. But the healthcare assistant or link worker or other staff can also use that consultation to advise about how do I recognize an exacerbation? What do I do if I feel I'm exacerbating? Who do I need to contact and when? Or how do I need to adjust my therapy? And thirdly, to use those consultations to support behavior change, lifestyle support, as I mentioned, around smoking cessation or physical activity. And all of these interventions by the healthcare assistant or other staff are supported by a range of digital resources that we have collated. And these staff can also provide these same interventions to the patients who are in high and medium risk in separate consultations. So we know that those interventions get done better, the support for education and self-management, for example, but also that will reduce the time that the frontline clinician has to spend with the patient. And the next slide, please. Thank you. So, and as I mentioned, I'm just going to show these as pictures, and in the detailed slide packs, you'll be able to look at them in more detail. But this is to show that we've used a similar approach to stratification for COPD with 3 initial groups and further stratification using the COPD assessment test, and then grouping of patients into high, medium, and low risk. And the next slide shows the interventions framed in the same sort of way for high and medium risk patients, but also the support for education, self-management and behaviour change for patients at low risk, but also applied to the patients in the high and medium risk categories. And the next slide, please. In type 2 diabetes, we've taken a similar approach again, developing search tools with the clinical effectiveness group for System 1 and EMIS. And these search tools identify patients with type 2 diabetes, and the stratification into priority groups is based on evidence of glycemic control with the HbA1c levels, complications for the patient, the existence of comorbidities, social factors, and ethnicity. And you can see we have 3 groups, the high, medium, and low risk. And we've used the glycemic control and other factors then to prioritize these patients into 2 groups for high risk and 2 groups for medium risk. And this, because the numbers of patients with these conditions are fairly large, it allows local teams to prioritize who they need to see first. And the next slide, please. Again, it shows a similar approach to the interventions. So aide-memoire for the clinicians looking after patients with high and medium risk, and more detail for the HCAs, link workers, nursing and associates providing the education, self-management and lifestyle change support to patients. And then finally, we'll move on to hypertension. And again, don't over worry about the detail in this slide. You can look at that in more detail in the main packs. But the approach here is slightly different in that we've developed 4 priority groupings. And this is based principally on levels of blood pressure control. So from the previous blood pressure reading in the patient's records. So priority 1, very high blood pressure, more than 180 over 120. Priority 2, above 160 over 100. Priority 3, above 140. And then for patients with controlled blood pressure, so under 140 over 90 if they're under the age of 80, or less than 150 over 90 if they're over the age of 80. So principally, the stratification is based on blood pressure control, but you'll see in priority 2 that we've added in other factors. So we've included patients at a lower level of abnormal blood pressure, but who are also from Black, Asian and minority ethnic groups, or who have cardiovascular comorbidities or risk factors, and also patients in whom we don't have a recent blood pressure reading. And the rest of the slide shows the good practice interventions by a clinician for managing patients with poorly controlled blood pressure, but then the a range of interventions that can be carried out by the healthcare assistant or other staff role with the appropriate training, and again supporting education about hypertension and cardiovascular risk, support for self-management and the support for lifestyle change. And the final slide in this section is to illustrate the pragmatic approach that we've taken to supporting change. This is all about, we know the good practice that we have to deliver. The challenge for us now is how can we deliver this in an effective way and in a safe way and an evidence-based way. So if we take blood pressure, one of the critical questions to resolve is how do we get our patients doing their blood pressure at home where possible. And so we have a line in the centre there for the patient with the blood pressure monitor who submits his or her readings. But many of our patients will not have blood pressure monitors. And on the right hand side there, it indicates how we can support patients to buy monitors, sharing with them advice on what are good monitors to buy, what are validated monitors, but also creating a pathway for patients who do not want to or are unable to measure their blood pressure at home. And on the left side of the chart, you'll see that through this pathway, we're addressing some of the other challenges. So if you're measuring your blood pressure at home, again, a further question is, how do we know you're measuring it properly? Because we know it can be difficult. And so the healthcare assistant or link worker or other staff would use video consultations, and they could be group consultations to support the patient to use the blood pressure monitor at home, to test that they're using it properly, again using tools such as the British Heart Foundation video on how to measure your blood pressure. But the pathway also addresses another critical question. If you're measuring blood pressure remotely, if the patient has atrial fibrillation, then the automated machines may give erroneous results if just using a one-off reading. And so the pathway shows how patients can be taught to check their pulse, looking for abnormal rhythm at home, and if it is abnormal, for them to have a device such as FibriCheck or AliveCor, which would allow them to get a diagnosis of atrial fibrillation or not atrial fibrillation at home. And if they do have atrial fibrillation, there is advice then on how to get accurate blood pressure readings at home. So the next slide, please. So those are the pathways. You'll be able to access them in more detail on the website. And I'm going to hand over to Laura now, who will take us through the offer that UCL Partners is bringing around supporting implementation.
Thanks, Matt. Before we move on to the implementation support, just to highlight some of the feedback that we've been able to get while developing these frameworks. So we've tested the approach with patients and public and carers to get their feedback. This slide just summarises some of the themes that have come back. So one is around communication and ensuring that patients could feel confident that even if it wasn't their normal GP that was contacting them from their practice, the person speaking to them was confident and had consistent messaging and information about their conditions. The second was around taking a holistic approach. So some of our patients said that they didn't want to just be contacted about an individual long-term condition, but wanted their wider health and well-being taken into account. And then finally, a key theme that came out was around trust and how the patient could be sure that the person contacting them was genuinely from their practice and how they would be using the information. And as I'll come on to, we've tried to build these themes and reassurance into the support package that's been developed. Secondly, also just to reassure that this has been completely clinically led at UCL Partners, and this is a list of our quite large clinical team who've been involved. So we've been quite clear from the start that while it's fantastic to have tools ready to deploy, just having those alone probably isn't enough to ensure that they're consistently and sustainably deployed across the system. So to that end, we've developed a complementary implementation support package to help with that implementation, and I'll just run through the components of this. So at the start you can see we have the search and stratification tools. So these are freely downloadable from the UCL Partners website, and the link is included here. There are also pre-recorded webinars on the site showing you how to use those search tools. There is wider support available from the UCL Partners team in helping local areas think about how they might prioritise some of the numbers that come out. The second, and probably the breadth of support available, is around how do we support the workforce to adopt and use the frameworks. So we've developed protocols or wording for healthcare assistants and others to use when contacting patients. And this is really to be used as a guide and to help take those individuals through the conversations that they will be having. Now, to help embed those and get people used to using them, we are working with Care City and are offering a course in both how to utilise the protocols, but also how to incorporate motivational interviewing and the principles of health coaching into those conversations, so that both healthcare assistant or other and patient has a really productive adult-to-adult conversation. The second is the practical training. So Matt highlighted the role of healthcare assistants and others in being able to demonstrate correct inhaler technique and so on. And we've amassed a series of links and video training sessions to help provide that training so that healthcare assistants can demonstrate inhaler technique, can help with blood pressure readings, and can give very brief advice for smoking cessation. And all those links can be found on the UCL Partners website. And then finally, we're working with local training hubs to offer specialist briefings on the long-term conditions, so that all staff can increase their knowledge and confidence about talking about any of the conditions that we've covered today. The third part of the support is around those digital support tools. So again, working with our clinical team and through our commercial and innovation team at UCL Partners, we've identified some of the key and freely available web links and innovations that can support both patient self-management to be embedded into the pathways, but also innovations that can help with the delivery of care. Now, there are lists of these available on the UCL Partners website. And again, there's support available from UCL Partners in embedding some of those innovations. And then finally, we're very keen to learn as we go, and we're working with City University to evaluate the acceptability and feasibility of this framework and the impact it has on raising workforce competence and confidence. And if after this webinar you are keen to take part in this, we would love to involve you within that evaluation. So more details about the whole package of support can be found on the UCL Partners website, and there's a link from the homepage. But if you do have any further questions, please contact us, primarycare@uclpartners.com. Thank you very much.